So, hello everybody, it's a pleasure to welcome you on this EAUTV interview. We're here in the beautiful city of Madrid for the EAU 2025 with two of my good friends, Dr. Ignacio Moncada from Madrid and Dr. Eva Fong from Auckland, New Zealand. So, what we want today is to discuss the highlights of this first day of the EAU, especially focusing on functional and reconstructive urology, but also andrology, so let's say benign urology, as we call it. And so we had already some very nice and interesting session from this morning. And the first question that I'd like to ask to you, Ignacio, is about what we've seen this lecture from Louis L'Enfant about electromechanical sphincter and how it may affect the treatment of male stress urinary incontinence. We know your expertise on that. Do you think it will be a game changer or not?
Yes, I think that it will be a game changer. I think that this is something that will improve the quality of life of the patients because they are going to miss the pump, which is something that is causing not only the pump, also the cuff, causing problems in the patients. There are many complications. There are mechanical complications or mechanical failures. There are erosions of the cuff, and that is because there's a fixed pressure on the cuff. So this allows the patients and the doctors to control the pressure of the cuff. You can deactivate that at night if you have a patient with radiotherapy and you want to, not to activate that or decrease the pressure during the night or depending on the activity. So I think it will bring a lot of advantages, and I think it will change the game. Of course, there are also problems with that. They will need to have a big battery, a big machine to move all the fluid to the cuff, and probably they will need to change the batteries every now and then. You need to recharge the batteries probably every 2 days or every day. I don't know exactly. It's like a phone. But at the end of the day, I think it will be something positive to the patients and to the doctors also.
So from what I'm hearing from you is that it goes beyond just getting rid of the pump. It's also all the new features of adjusting pressure. Okay.
I think that is the interesting part for the doctor, because of course as doctors we don't have to manipulate the pump. It's the patient. But from this point of view of the doctor, I think that will improve the results a lot.
And Eva, if I may ask you about the female stress urinary incontinence population, I think electromechanical sphincter are very appealing for that population too, right?
Definitely, because I think for women, the pump is the most off-putting part of the device. They have to pump it so many times to move the water. They find it uncomfortable, they find it disfiguring. So I think it's going to expand the market hugely for women. I also think that with the battery, if we look at sacral neuromodulation, there's going to be a very rapid improvement in the battery. There has to be. And I think there needs to be competition in the market to push that, because suddenly we saw with SNS, after many years of no change, suddenly everyone's gone to the 15-year battery. Everything has become so much better. So we need to not only take the first new product, we need to encourage the competitors so the product very rapidly becomes ideal.
Mm-hmm.
Yeah.
And when you mention competition, Eva, if I may, I think Louis L'Enfant nicely emphasized that there are two different types of cuffs that we can have with electromechanical sphincter, the hydraulic cuff versus the mechanical cuff. What are your thoughts on that? Do you think one is more promising than the others?
I'm not sure about that, and I haven't heard about any comparative studies between both, so I cannot say. But I'm used to the hydraulic, to the one that is using saline, and I think to me I think it's probably better because produces a more better distributed pressure around the urethra. But I'm not sure. Probably the other one is they will test and they will check that it's safe also. But I don't have an opinion right now. I think you will see with time.
What would you think of that, Eva?
Well, I prefer safety. So I prefer to go with the hydraulic cuff because it's a known quantity. And, we know the properties of the cuff have been tested for at least 30 years. So we're only changing one thing at a time. So for me, I would prefer safety first and then see how the other product develops over time.
Yeah, and of course, as you said, both of you, the evidence will be there and we'll see how it goes in the patient and the results, etc. So great. So I think that was one definitely of the first highlight of this first day was electromechanical sphincter. Then another highlight to me, really, Ignacio, was your lecture, because I'm always curious. We all have these patients who have both, so those male patients after prostatectomy, sometimes radiation therapy, they have erectile dysfunction and stress urinary incontinence, and we never really know how to deal with them when they need surgery. Do we need to do sphincter first, implant first, both at the same time? So can you tell us about your lecture?
Yeah, well, I mean, I think if that's something that you always think about, what should I do with the patient with urinary incontinence and erectile dysfunction? The thing is that most of the patients that have incontinence, they will have also erectile dysfunction. There are many patients only with erectile dysfunction, and of course, they don't need a sphincter. But in the case of having both, and some patients that want to have a solution for both problems, one question that raises is, can I do safely the double implant, so implant both things at the same time, and the patient avoid one surgery is probably cheaper for the patient or for the system. I think that is what I was looking at. I was making a review of that, and there is enough evidence to say that it's quite safe and efficacious to do that combined. Do this one surgery, implant both devices. Of course, there's more complications with two devices than if you implant one alone. One sphincter or only the penile prosthesis there are less problems. But even though I think it's worth to try and to do that, because most of the patients are going to be happy. They're going to avoid one surgery, and I think it's a good step in this the management of these patients.
So thank you very much, Ignacio. It's very clear, I think, for the audience, and at least we understand how to manage those patients. A question about one of your lecture, Eva, which was about managing the painful sling, because we all know about the mesh controversy. I think synthetic sling, we would all agree, have helped a lot of female patients with incontinence, but some of them have difficult complications, and one of the worst probably are those like pain, pelvic pain, and we never know what to do. Can you give us some insight about your lecture on how you would manage those painful sling patients?
Yeah, I think a lot of them are managed surgically, which is what I said, but the important thing is to manage their expectations. And so what we know is that if you remove the sling, probably only about 50% of them will have an improvement in pain. So they need to adapt to a new normal. And I guess the worst thing about the new normal is they may also be very wet. But what I didn't say in my lecture is we are not just making them wet, they are already wet beforehand. So one thing I really dislike is that people put the sling in very tight because they're so afraid the patient will not succeed with stress incontinence. So they obstruct the patient, and the patient is dry for a few weeks, but then they become wet again from overactive bladder. And so when I see the patient with pain, they also are already very wet with overactive bladder. But someone is telling them, we can't cut the sling because you'll be wet, but they're already wet. So I think the most important thing is it's not just the pain, it's everything else they're dealing with as well. So we've got to try and optimize every aspect to try and give them some improvement.
And so we've also seen in your lectures that you're using the robot to remove those slings many times. So can you tell us how it has changed your practice and how much of those mesh removal you do robotically versus other approaches?
That's right. So we only do the transobturator open, and we do most other things robotically. So we remove the retropubic sling. That's the most common. We remove the transvaginal mesh, which we saw, and we also remove the sacrocolpopexy mesh robotically. And I think that's amazing because the patient is already in a bad condition. She's already in pain. I don't want to give her more pain with the surgery. So I want to be minimally invasive. I want to make it easy for her. I want to give her the best chance of recovering from the pain. So I think the robot's amazing for that.
Can I ask you, what do you think is the reason for the pain? Is it an infection of the mesh, or is something else?
I think infection is not super common. There was a lot of theories about that, but usually we don't culture anything from the mesh. I think actually it's usually misplaced and usually very tight. And I think where there is tension, there is ongoing inflammation. And so instead of our body learning to tolerate the foreign device, because of the tension, the body keeps on treating it like a new implant and keeps mounting an inflammatory response. And then there's a lot of fibrotic tissue. Perhaps the fibrotic tissue pulls on nerves, etc. And that's probably the etiology of the pain.
But we have also patients, male patients, that you implant a mesh, like a fixed sling, and they have pain also. Of course, you need to put a lot of pressure. So I don't know, if you don't put enough pressure, it will leak. If you put too much, maybe it's painful.
That's
so
right.
sometimes you're in this.
And in the male patient, I think you do have to put more pressure than in the female patient. In female, it's very much tension-free. In male, you do have to put that pressure, but maybe it can cause pain too, I agree.
Yeah, sometimes painful. Yeah.
And so, we were mentioning how you use the robot for that. We have had, I think, a great session about robotic functional and reconstructive urology as well. And one thing that joins those two topics that we have been talking about today is robotic artificial urinary sphincter. So I'm glad that you too brought that up, because I have a conflict of interest. I'm a lover of female AUS and robotic female AUS for a long time, but I think you share this excitement. So can you tell us about robotic female AUS and how you think it's evolving, etc., Eva?
Yeah, I think it's very exciting, and I think it's an area where it shows us that we've always got to have a growth mentality. You know, we have a point in our training, and you and I, Benoit, spoke about this. We both travelled overseas for the last part of our training. And when we travelled overseas, we realised that so many of our practices we're taught because we are taught by the teacher and we practice like them. But when we go overseas, we see a whole new world, and we expand the way that we think, and we bring new things back to our country. And so I think AUS is like that for me. It's a game changer, especially when done robotically. I don't think I'd want to do it open. I think it's a much worse operation open. Much more complications, difficult for the surgeon. And I think, like I discussed with you earlier, I think it's got a much wider application than we think. You know, like what Vincent said, so many of our patients do have a significant component of ISD. So no matter what we do to them with everything else, they're not quite dry. And I guess it's a difficult question of whether AUS sits in the algorithm. I mean, we've also discussed previously, if you do it too late, then it's a very, very difficult operation. So I think we have to change the SUI algorithm, like the OAB algorithm has changed recently.
Yeah, and I think it's actually a very good message that you bring up, and maybe a good concluding message for all of us is you mentioned taking ideas from abroad, and I think EAU, in a way, is very much like this. We are from all over the world, all together here for a few days. We're sharing ideas, views, and expertise, and we see that in our world of functional andrology and reconstructive urology, we have different practice from different parts of the world, and so this is a good time for us to, share those thoughts and exchange, and probably I hope all of us and all of the audience will have new ideas for their patients starting next week. So that's probably a good way of concluding that session, and we're very excited to have had this time to discuss together. I hope you all have a wonderful meeting, and we hope to see you soon in the next session at the EAU.